Welcome to the second part of my lecture on growth disorder. Today I'm going to talk about tall stature. This is Dr. Bhomik. I'm a pediatric endocrinologist and professor of pediatrics, University of South Alabama College of Medicine, and an senior attending in children and women hospital at Mobile, Alabama. I just retired from there. So we are going to talk about tall stature, and the first lecture you have heard about the short stature. Well, not too many cases will be referred to you for tall stature because majority of cases of the tall statures are familial, and it is a normal variance and what we call constitutional tall stature, and their parents are also tall. We'll be talking a little bit more about them. But non-endocrine cause is the one that is concerning, and they come to us because of tall stature, but they has other uh, morbidity and mortality, and we'll be talking about those also. And the endocrine cause is extremely rare, and we also spend a little time on that too. The one that we need to know is the constitutional tall stature. These babies are born with the normal birth weight and normal birth length, and the changing of the percentile occurs exactly in the same way it occurs in the constitutional delay of growth. By that I mean they change their growth percentile between 6 months to 24 months, and they shift upward. So instead of growing the average centimeter per year, they go upper limit of the average. So in first year, average growth is about 10 inches, but they will grow 12 inches, and that's the upper limit of the normal. Therefore, they will change their growth percentile upward, and that's how they will continue. And growth velocity is upper normal, as I said, and there is family history of tall stature. Sometimes we may not find clearly and with mom and dad, but there is uncle, grandparents, or aunt, they could be tall. And we don't see that many of that referral. And bonus is identical with the chronological age. Therefore, the timing of the puberty is also normal. And if you do any laboratory evaluation, they're all going to be normal and no treatment is necessary. There is one uh, section of the people they present with tall stature, which I call pseudo tall stature, because they are at the end of the growth, they are not tall. Actually, they are short. But in the beginning, they present with tall stature. The best example is exogenous obesity. And about 70% of the obese children in early adolescent or late childhood is on 70th percentile. So there was a statement made, and they said 70% of the children with obesity, by the time they're 7 years of age, are on 70th percentile. And if a child presents to you with short stature and obesity, and that is concerning, and they need to be evaluated, and especially they need to be evaluated for Prader-Willi syndrome, hypothyroidism, growth hormone deficiency, and making sure they have no other syndrome. So there is another category is congenital adrenal hyperplasia, precocious puberty, or any condition associated with excess androgen or estrogen secretion. The constitutional congenital adrenal hyperplasia in non-classical form, and sometimes they may not be picked up early on, but they present with tall stature and precocious puberty. Their bone age is advanced, and therefore, at the end, they end up in being a short person. And there, the one is uh, when seen by the pediatrician, and they refer to us for tall stature, but indeed they are what I call pseudo tall stature. They're tall now, but at the end of the growth, they will end up in being short. The one that actually your favorite board question is cerebral gigantism, and also known as Soto syndrome. Dr. Soto described this condition long time ago in 1964, and the characteristic finding is all are in this slide. They are, when they are born, they are lengthwise, they are tall. At the same time, they are also weight-wise a little bit overweight. So they are big as they born. And that growth persists. And the tempo of that growth persists for 4 to 5 years. And after that, actually, the growth velocity and weight gain become within normal range. This is a rare genetic disorder caused by the mutation of NSDI or nuclear receptor binding set protein, and they are located on gene. The gene is located on chromosome number 5, autosomal dominant, and the puberty occurs at normal time, maybe a little bit early, because if you do the bone age is identical with the height is. So they are a little bit advanced, therefore puberty might come a little bit early. And the other thing is very characteristic of Soto syndrome is they have awkward gait, poor coordination, and the other features looks like acromegalic, big head, uh, coarse skin, and a long and thick hand and feet, somewhat thick subcutaneous tissue, prominent jaw, and their IQ wise is around 70. And so these are the children should be followed carefully because proper counseling and the training might help to increase their IQ. The next one we're going to go and discuss about the Marfan syndrome. Marfan syndrome is a disease of the connective tissue, and it is autosomal dominant to 75% of the cases, and 25% of the cases it is a new mutation. So 25% it is a de novo, and they are tall in stature, arm span is decreased, but upper lower segment ratio is also decreased. Arm span is increased and decreased upper to lower segment ratio. If you are looking for the gene, this is FBNI or fibrillin related nuclear gene 1, and it is on chromosome number 15, and this can be checked now by checking the blood and saliva about 95% accuracy. And the Marfan syndrome, the the favorite board question that they usually ask, the two things, eye finding and the cardiovascular finding. So eye finding, the Marfan has anterior and upward dislocation of the lens, abnormal joint movement, laxity of the joint, sometimes even misdiagnosed like Ehlers-Danlos syndrome, pectus excavatum. Uh, comparison with the comparison with the homocystinuria and Marfan syndrome is another common board question, especially when it comes to the lens dislocation. The way I remember that when you go to Washington, D.C. and go to the Lincoln Memorial Hospital, and Lincoln statue is so high, and you really have to look upstairs or up to look for the look to his face. And so that's why I remember the upward dislocation, and the opposite is homocystinuria. The cardiovascular defect is the one most concerning, and that's what they get killed. They die very suddenly. The cardiovascular is the aortic aneurysm or dilatation of the aorta at the root. There is also mitral regurgitation. Mitral valve prolapse also occurs, and therefore cardiology follow-up is very important. And if follow-up is good and they have uh, provided the supportive care, and their prognosis is pretty good. The average longevity in one series was about 70 years. The homocystinuria is a disorder of amino acid metabolism, which we will talk a little bit more in the metabolic lecture, but it is autosomal recessive, and they look like Marfan syndrome or tall stature with Marfanoid habitus, and this is because of the enzyme deficiency called CBS or cystathione beta synthetase. And this enzyme is necessary for the conversion of homocysteine to methionine. In the absence of the enzyme, the homocysteine level goes alarmingly high, and which is very toxic to the brain. Mental retardation and downward dislocation of the lens, osteoporosis, thromboembolic phenomena is rather common. More important thing to note that the homocystinuria could be very sensitive to vitamin B6, and this should be started early on. And if they're B6 sensitive, pyridoxine sensitive, then they do rather well. The other one is Klinefelter syndrome, and I did discuss this one among your um, board review case discussion, Klinefelter with gynecomastia. But I'll just try to go through that very quickly. Klinefelter is the most common chromosomal anomalies in male, and just to compare that, in female it is the Turner syndrome. But Turner syndrome is 1 in 3,000, and Klinefelter syndrome is 1 in 1,000 to 2,000. Their average height is about 185 centimeter. They have long leg and long arm span. Characteristic finding is testicular volume. Although they go through puberty, but there is a deficiency of the pubic hair, and they may not complete puberty since there is a testosterone deficiency. Although there is enough testosterone to start with, so they go through puberty. Testicular volume is almost always is less than 12 ml, and adolescent gynecomastia is one of the findings. And most of these children is not diagnosed until they present with gynecomastia or failure to progress puberty. And they have also go back, and you can find the history of some behavioral problem, delayed psychosocial, and so forth. And the karyotype is 47XXY in 70% of the cases, and the rest are mosaic. And these mosaics are the ones sometimes difficult to diagnose. Laboratory classical finding, you will see that they have elevated FSH and LH, but low testosterone. Elevated FSH, LH, and low testosterone. And there is a fibrosis of seminiferous tubules, and as you know, 70% of the weight of testicle is seminiferous tubule. So there is a fibrosis of seminiferous tubule, and that lead to the oligospermia, azoospermia, and infertility. They have also very higher incident of various type of autoimmune disease. Growth hormone excess, I'm just going to mention because this is such a rare case, and there is about 100 case report in the literature, and we are one of the fortunate who are reported one case at 2008 with a typical growth hormone excess secondary to pituitary adenoma. And it's very rare in children since it occurs before the closure of the epiphysis, so they call gigantism. And once the epiphysis is closed, that known as acromegaly. And abnormal growth velocity very start soon, but usually after the age of 2 or so, it is continue to go up and up. And average height is above 8 feet, 8 or 2 or 8 has been reported in the literature. And if you just do the random growth hormone, normally it's low, but in this case, you will find that even the random growth hormone may be much higher. But the specific test that for the screening of this condition is going to be IGF-1 and IGF-PP3, as they are going to be invariably elevated. And about 50% of the cases, the prolactin level is also high. And once the condition is diagnosed, and this is mostly due to the single pituitary adenoma, benign pituitary adenoma, and it is then they are sent to the neurosurgeon and usually treated by transperineal surgery and followed by somatostatin analog octreotide. And obviously, after surgery, they might develop multiple hormone deficiency, and the endocrine follow-up is more or less will continue throughout their life. Thank you very much for your attention.